Hello, my name is Veronica Ajewale. I'm an associate professor of pharmacy practice and the director for the Community Engagement Core of the NIH-funded Center for Biomedical and Minority Health Research here at Texas Southern University. I want to say a big thank you to you and the community members for joining us for today's program. We are really excited that we will be sharing a lot of great information alongside the experts of speakers and panelists that will be leading us into this conversation. So please have your questions ready. We would have an opportunity to take your questions after today's presentations. So thank you again for joining us, and we look forward to our continued collaboration. Thank you.
Thank you. So you're welcome again to today's webinar education titled Let's Talk About Male Breast Cancer. Thank you. Next slide. And just a brief review of who we are and what we do. Again, our center's name is called Breast Cancer Screening and Prevention Center, and we are privileged to provide a few services. And they include breast cancer screening and diagnostics, patient navigation and barrier reduction, and breast cancer awareness and education. Under our principal investigator, Dr. Veronica Ajewale Muema, we're privileged to have in the past 3 years received $1 million from CPRIT, which is the Cancer Prevention Institute of Texas, from the years 2021 to 2024, servicing 5 counties initially. Now we've expanded with the $2 million grant we just got renewed this July 2025 to 4 other counties. And the counties include Harris, Grimes, Matagorda, Walker, Wharton, Brazoria, Galveston, Polk, and Trinity. We provide screening mammogram services, and thankfully we have been able to screen over 1,600 women. We also have provided education to over 5,000 women, as well as navigation services to 5,600 women. Next slide. And this is our great team without which this great work we do would not have be made possible. Of course, you see at the head here is Dr. Ajewale Muema, who is the principal investigator as well as program director. Dr. Annalise Gonzalez is our breast medical oncologist and co-investigator. And you see myself there as co-program director. We have Dr. Duha Al-Kayad, who is also a primary care provider. Dolores, you've got who's also our care coordinator and does amazing work with both our Spanish-speaking and English-speaking patients. Alongside with her is Kiki and Lauren Hunt, who also provide care coordination and program coordination services. Dr. Rodney Hunter, who you will hear from shortly, is also our co-investigator. Ms. Rosalia Guerrero is co-investigator. Laura O'Toole is our wonderful health literacy consultant that makes sure that the information we are trying to send out to you is broken down into a language that everybody can understand. Ms. Amanda Hakla is our program evaluator. Ms. Sneha George is our community health worker who also provides outreach coordination. And of course, Cassie Thompson is our administrative coordinator. Next slide. And here is our TSU mobile health unit. You saw a video about it just a few minutes ago. Again, Dr. Veronica Ajewale Muema is the founding director for this mobile health unit initiative, the first of its kind here at TSU. We're privileged to have it all done and ready, and what we are looking for right now is potential partners and those that would like to donate even towards this initiative, so we can take this out into the community and provide both primary care services, community engagement services, as well also as screening mammogram services. Next slide. And here also is our innovative community-focused clinical research program, and this was launched in May 2025. Also an initiative spearheaded by Dr. Veronica Ajewale, and also her coordinator in this program is Mr. Mark Ibarra, who has done a tremendous job with helping to set this up and launch it. Now, what is this clinical research registry? It is pretty much a type of data repository where participants are enrolled in a database or registry, and we just collect and store detailed information about you over a detailed period. This information includes your demographics, your contact information, your medical history, and other relevant data. Now, you might say, why should I join this? This gives you early access to potential clinical research. You are able to be part of groundbreaking medical discoveries, and you're also, of course, helping to improve treatment options for your children, your grandchildren, and others down your line. Now, who can join? Anyone who is healthy or anyone who has a medical condition. You have to be, of course, be 18 years or older, and anyone from any kind of background is welcome. Now, there is no obligation for you to continue or discontinue. You can just pick up the phone anytime and ask for your name to be removed. But pretty much this is a way of having our community members be part of clinical research that is taking place, so that when a drug comes out, we can say, oh, I was part of this, and your children or grandchildren can also benefit from this. Thank you. Next slide. Now, again, thank you to our participants for joining our attendees. Please go ahead and start posting your questions if there are anything, but also we keep on sending out links for you to post your questions, and we'll keep on reviewing them and try to answer them during this webinar session. But again, just in case your question is not gotten to, we will send out a link on our link tree with answers to those questions. For our CHW, our community health workers, thank you for joining us as well. You are able to claim one credit hour from today's event. But please, in order to be eligible, you have to fill out our CHW CE attendance sign in, and also complete our survey that you will see also when you scan this QR code. It's in our link tree. We are streaming as well live on Facebook and YouTube. We are grateful for your attendance, and please, we invite you to share this link out to those whom you believe will benefit from today's talk. Stay connected to us by following us again on social media. We also have our website where you can also stay posted on everything going on with us, as well as our link tree, and we have a number there for you to call should you have any questions for us. Thank you. Now, without much further ado, I want to present Dr. Rodney Hunter, who will be giving us today's breast cancer education talk. He is a PharmD as well as a board-certified oncology pharmacist. He's a professor at Texas Southern University's College of Pharmacy and Health Sciences in Houston. He's also the director of clinical services at Memorial Hermann Texas Medical Center, clinical assistant professor at the University of Texas Health Science Center at Houston McGovern Medical School, as well as a clinical pharmacy specialist at UT Health Memorial Hermann Cancer Center in Houston. Dr. Hunter received his Doctor of Pharmacy degree here at the esteemed TSU, followed by a fellowship in oncology at the University of Texas MD Anderson Cancer Center here in Houston as well. He has led various grant-funded initiatives with funding from National Institutes of Health, and has served and currently serves as co-investigator for our CPRIT-funded TSU BCSPC program. His clinical interests include breast cancer, pharmacogenomics, and healthcare outcomes, and chemotherapy dosing in special populations. His work has been published in quite a number of journals, including Pharmacotherapy, Journal of Cancer Therapy, and Pharmacy Technology. Thank you, sir. Over to you.
Thank you, Dr. O. I appreciate that introduction, and I'm definitely excited to speak with the group today. Let me share my screen. Okay. All right. So as she was saying, I think I have a special interest in breast cancer, and of course, typically when I'm doing these presentations, it's focused on women. And I'm actually excited today to bring to light some of the facts and the details and the nuances that are related to males. I speak a lot on prostate cancer, and we have a prostate cancer program we speak extensively about, but I think breast cancer is something for males that we have not spoken much about in the past, and I'm excited to talk about it today. And then the goals of this short presentation, as we'll complete this, we'll have more panel discussion topics and questions to be answered. We'll review like the breast and how things look for men versus women. We'll talk about some of the common anatomical and physical differences between men and women when it comes to their breasts. Talk about various types of treatments that patients may undergo if they get breast cancer. Some healthy habits and lifestyle changes that may be able to be made to decrease the risk of breast cancer, and also share some places where you can get more information about breast cancer in general if you have a family member or you have high risk of breast cancer. And I think that's going to be probably the driving force and something I definitely want everyone to take home, because family members that have breast cancer, regardless of their sex, is actually important to show how much risk you have as an individual, even if you're a male. So looking at the breast, of course, when you think about the breast, it's actually overlays your chest muscles. So all of that tissue that's above the chest muscle, which typically it's good amounts of fat there. In males, there tends to be a substantially lower amount of fatty tissue than you see with females. Now, what you do see when you look at the breast tissue is like the shape. The shape can stay consistent because it's really just molded by the connective tissue that's under it. There are lymph nodes that are actually towards your armpit. They're all around, but the armpit lymph nodes are the axillary lymph nodes. Those are the ones that we're very always suspicious about if somebody gets diagnosed with breast cancer. We want to make sure there's nothing that's there. There's, of course, adipose tissue and that fat tissue that's all around. There's actually hormones that are releasing that fat tissue. And that's why, the breasts are very prone to getting cancer in the first place. In males, unfortunately, because there's less fat tissue, it's harder to detect breast cancer. And that's why when we start talking about some of the stats, you're going to notice in females, we end up being able to diagnose it earlier. And in men, we actually diagnose it later. And it's because of the tissue that we can scan and identify the densities in the breast. It's very difficult to do that in males. Males do have ducts in the breast just like women do, but they typically have very small or no lobes in the breast. The ducts and the lobes become important because those are the major places where breast cancer originates from. You can have breast cancer that comes out of the ducts, or you can have breast that comes out of the lobes. And of course, in males, because we have little to no lobes, most male breast cancer is coming from the ducts. So when you look at the numbers, and I myself have had several male patients in my career. I usually have a couple of them, 2 or 3 of them a year here at the cancer center that I practice at. 2,800 males will be diagnosed with breast cancer in 2025 in the United States, and 510 are expected to pass away from breast cancer in 2025. And your lifetime risk is relatively low at 1 in 755. But I think the idea and what I always want to drive home is that when males get diagnosed with breast cancer, it's typically more advanced because it's not something that's regularly screened. When you think about what is happening when you're going to your physicals, the physicians are typically going to be focused on things like colorectal cancer, prostate cancer, cancers that we as males get more frequently. But it is still something to hear and something to know that it is a possibility for this type of cancer, especially if you have strong family history. When you think about where the cancer starts, it's something that affects like how well we can treat it, if it's invasive versus non-invasive. And when we use those two terms, invasive is the cancer that can spread outside of the breast area. Non-invasive means it's actually limited to only that particular area and it's not going to go anywhere. We a lot of times will call these like benign tumors that we'll just remove, and you can go on about your life and your business and not have to worry about things. We also do want to check like the receptors and the signals that the breast cancer is responded to. That helps us decide what treatment we want to give our patients. So some symptoms, and definitely like, these symptoms are not always as identifiable when you look at males, but still want to let you guys kind of look at them and hear about them. Lump, of course, is the first thing and the most often thing a patient can self-identify. Swelling in the breast, dimpling or puckering of the breast. Skin on the breast, having changes on the skin of the breast is actually something that people don't identify with breast cancer, but inflammatory breast cancer and breast cancer that's involved with the skin, which it can be involved with the skin, it will change the appearance of the skin. So it can be a sign or a symptom of possibly cancer on the breast, just a skin change. Scaliness of the nipples, lumps or ulcers around the nipple, or the areola. These are all things that you want to identify, you want to watch out for. And even when you look at these symptoms, they are always going to be the signal of breast cancer, but they may be a signal for another type of health problem. So you always want to follow up with your physician that takes care of you to if you have any of these changes you identify. Several women, specifically as well as men, have identified things on their own and then brought those to their physician, and that helped save their life because they did have breast cancer. And if they would have waited maybe for their scheduled mammogram, it would have been years in the making of them actually before they received treatment, because it wasn't time for them to get screening, or if they were a male, then they weren't going to be screened for breast cancer anyway. So what type of things do we as men have to worry about and we have to watch out for when it comes to breast cancer? Specific thing, age is a factor. So on average, you're typically going to see males above 60 who are diagnosed with breast cancer. Genetics, the BRCA mutation, the BRCA1 and the 2 mutation, that's something that is hereditary. That's something that people in your family have it, then you should get screened to see if you have it, because it does increase your risk of breast cancer amongst other. There's a few other cancers it can affect as well, but breast cancer specifically in our conversation, if you have that BRCA mutation, it causes us to be more aggressive with the way that we screen you, and then family history. As more and more direct relatives, whether it be a child or a sibling or a parent, have breast cancer, that increases your risk individually of having breast cancer. And so that's something else that increases the screening aggressiveness when we see somebody who has a history of breast cancer in their family. Alcohol use, estrogen treatments, those are things that increase the risk. Alcohol use specifically is actually linked to hormone activity in breast cancer. About 70% of breast cancers, and this actually includes males or females, is driven by estrogen and progesterone. So those are two sex hormones that women have predominantly, but we as men also have these hormones circulating in our body at lower amounts. But the key is that the alcohol use can actually it's been associated with an additional activity of estrogen specifically. Excessive body weight, because as we begin talking about having our conversation about breast cancer, the more adipose tissue you have, the more estrogen exposure you get. So that's something to be mindful of. And anytime there's any testicular conditions that decrease the amount of testosterone you produce, testosterone and estrogen kind of fight against each other, if you will, so they control each other, and they originate that the basis of both of them is similar. So if you have decreased amount of one, it actually causes you to have some disproportionate amounts of estrogen activity, which can increase the risk of breast cancer in males. Screening mammograms and breast ultrasounds are still actually appropriate to do, and we have those abilities. Of course, you heard about our mobile mammography unit, and we do several events across the greater Houston area for breast cancer screening. I will tell you that when it comes to men specifically, the mammogram really focuses on changes in density in the breast, and that really requires you to have good amounts of adipose tissue. So when you're doing like a screening mammogram in a male, it's much tougher because it's similar to like a female that has very dense breast. It doesn't really pick up tumors as easily. So that's when you have to go to the much more, it's more expensive, but it sometimes be more sensitive. It's things like breast ultrasound. So that's another aspect and a thing to talk about with your physician, or the physician who's responsible for taking care of you. So also, when you look at the biopsies and the molecular diagnosis of breast cancer, the biopsy is always going to be a confirming diagnosis, because if we just see a tumor or a lump, that doesn't mean you have breast cancer. We need to get some of those cells out. We need to look at them. We need to study them. We need to see what kind of receptors are on those cells, and that helps us personalize your treatment plan. as well as make decisions on how aggressive we want to be with the treatment we recommend for you. So very important that once we get that diagnosis, that we get some of those cells to do some more studies on them. And these are just like the types of receptors and types of breast cancer someone can have. Like I said, hormones drive 70% of all breast cancer growth. Most people are diagnosed, they have some type of hormone exposure, and we want to know that that's present because that helps us to direct our treatment. There's also another portion of growth that goes with breast cancer called HER2. And that pathway we can check when we get some of that tissue to see if that pathway is overexpressed. And then triple negative breast cancer is the breast cancer that doesn't express any of these types of growth patterns. And so that's we treat that one another different way. So breast cancer in itself is treated in 4 to 6 different ways, depending on your age, your hormonal status, and your HER2 status. So it's a very complicated cancer to treat, but the great thing about it is we've done so much research to really answer a lot of the questions. And chemotherapy is definitely there. There's radiation therapy that you can use. There's surgery that you can utilize in addition to the chemotherapy and the radiation. The medical oncologist is typically the one that's going to give you your chemotherapy. They're going to be leading your chemotherapy journey, and that's actually the area that I work in. I work in the medical oncology area. So those solid tumors like breast cancer, or the hematologic tumors are like leukemias and lymphomas and those types of cancers that come out of your blood. These are the types of patients that I take care of on a daily basis. And then radiation therapy is always important to decrease the risk of recurrence, so you ensure it doesn't come back. And we look at prevention as we kind of come to an end before we get to our panel discussion. Just staying at a healthy weight when you're a male is very important. Like I said, the addition of adipose tissue increases the estrogen exposure, and that causes you to possibly have an increased risk of breast cancer, especially if you already have you have increased risk because of family history or a BRCA mutation, all of these other things that we previously discussed. Avoid or limit alcohol use. As I said, it does have some estrogenic properties when you're drinking excessive alcohol. That's been studied. And then for men who are at higher risk, I think the genetic counseling is always an important thing. Being very mindful of your changes in your body. We talked about those signs and symptoms, those skin changes, those lumps, different types of dimpling around the nipples. All of those things are signs that you maybe could have breast cancer, but if not that, then you definitely need to take a look and make sure you're being monitored and screened if there is some type of lump that has not been verified as breast cancer, but is also changing in size, or is you can feel it when you're examining your breast area. So places where that great help comes from, I think that foundationally, the American Cancer Society is the gold standard when it comes to, I think, patient-friendly information that you as a male or female or a family member can obtain. MD Anderson has great resources. Memorial Hermann, which is my home hospital, has great resources. The National Breast Cancer Foundation, as well as Susan G. Komen, are great resources for patients to draw upon when they're looking at where they can get information about different types of cancers and direction on if they are needing assistance with actual care. And we have some websites here as well. I know these slides will be shared with the group, so you can refer back to them. Of course, I said a lot of things in the past 15 to 20 minutes, so not expecting you to remember all of it. Just know that there's resources for you as a male, and that just being mindful of family history, screening, and really just knowing your body and staying very active and limiting your alcohol intake, I think, are great places to start if you want to look at like how you can reduce your risk of breast cancer as a male patient. And I'll take any questions, any comments. I know we're going to go into the panel discussion, but definitely enjoy kind of sharing that information with the group, and thank y'all for y'all's attention.
Thank you, Dr. Hunter, for that great and insightful session of education. We're going to share our screen again just to go in so I can introduce our other panelists as well for this next session of Q&As. And thank you again to all those who are here and tuned in. You left whatever you were doing to come listen to this educational webinar. Thank you so much. And we hope that it blesses you and you're able to share that information as well to others. Please feel free to post your questions in our Q&A box. I know I've answered one question from somebody today. Again, you can scan the QR code as well and go into our link tree and fill out the survey, which is very important for us to know how we're doing, to know how we can better serve you, and to also provide feedback for the person who is sponsoring this, which is our grant partner. Thank you again. I'm going to go on next to introduce our next panelist person. Thank you. Dr. Richard Petrie is says this, that when he was informed of the diagnosis of male breast cancer in 2023, that he was very overwhelmed with disbelief. Breast cancer was something, of course, he had not associated with women. And in 2016, when he was informed that his breast cancer was stage 4 or terminal, that, confronting a reality that would test the core of his resilience, it was then he truly discovered what it meant to live with purpose. Instead of surrendering to despair, he said he became conscious. He made a conscious choice to focus on the possibilities. And his hope is that his story, it becomes one of human spirit, perseverance, and the belief that hope is always, always, always within reach. Thank you so much, Dr. Petrie. Please feel free to unmute yourself as well as turn on your video. Thank you. And the next person I'm also going to be introducing is, again, the principal investigator for our Breast Cancer Screening and Prevention Center, and the person of Dr. Veronica Ajewole Moema, who would assist in moderating this next Q&A session. Thank you so much.
Awesome. Thank you very much, Dr. Obo, for that kind introduction. Dr. Onta, that was a great presentation. Even though we've had opportunities to always work with Dr. Onta, we've had multiple presentations on breast cancer, but this is the first time historically that we are focusing on male breast cancer. So we are very grateful to you, Dr. Onta, for your willingness to share your expertise with us. And Dr. Petrie, thank you. We are grateful, for your willingness to share today with us and with the audience. Dr. Petrie, I see you are off mute, but we still do not see you on camera. I think your camera is currently turned off. If you're able to come off camera, we would love to have the opportunity to share. Okay, yes, we can see you now, Dr. Petrie. We are very, very blessed to have Dr. Petrie join us today. And if I can share a little bit of history of how we came across Dr. Petrie, when we received this $2 million award and an announcement was made on TSU campus, Dr. Petrie actually reached out to me and he was like, "Hey, Veronica, I have a story to share." I'm like, "Of course, Dr. Petrie, let's connect." Dr. Petrie, both of us connected via Zoom, and he sincerely shared his story. And I'm like, "Hey, we cannot keep this behind the wall. We need to be able to share this with the community, because breast cancer, even though it's more prevalent among female population, we also want to be able to highlight the day-to-day impact of breast cancer among males." So Dr. Petrie, it is a pleasure to have you on this webinar with us this afternoon.
I'm happy to be here.
Thank you very much. I have a couple of questions that will get us started with today's conversation. Audience, thank you for joining us online and in all the various platforms. Please feel free to keep the questions coming in the Q&A box. We will be walking through those as time allows. But Dr. Petrie, let me start with you. How did you first notice that something was off? Did you feel a lump? Was there a nipple discharge? Or what exactly prompted you to seek care regarding your breast health?
Well, for me, it was quite unique because normally I don't watch TV with my wife, but we were lying in the bed watching TV one Sunday afternoon, and for whatever reason, I felt on my chest, and I felt this knot, and I said, but I had heard of male breast cancer from uh, the actor and other people. But so I asked my wife to feel, and she said, yes, she felt it. So the very next day, I scheduled an appointment with my primary care physician, and he did a fine needle aspiration and said it is negative. I wouldn't worry about it because men don't normally get breast cancer, but I'm going to schedule these appointments for you. And so he said men didn't normally get breast cancer. So this was in December of '02 that I discovered this knot. Well, I was working in the yard in May of '03, and I said, I need to go get those tests done. And when I went to get the test done, well, to my surprise, I discovered that there was something there. And I knew it was really serious when the doctor said, we need to do an a scan. And he said, we'll do it for free. And I said, well, it got to be bad if they're going to do it for free because they don't work for free ever. So that's kind of the beginning of my story. And ultimately in June of '03, I had surgery for breast cancer. And everything went well. I mean, it was an interesting surgery. Uh, my Actually, my doctor and I didn't last very long because he wanted me to go to one place, and I was out of town actually because I was associate provost at that time, and I was out of town in Austin. And I called my wife to tell her that the doctor had called me, and he just said, "Richard, you have cancer." And so okay. And so I called my wife the next morning. I didn't want to interrupt her night's sleep, so I was telling her that what the doctor had said, and she said, hold on. And she came back to the phone and she gave me the number to MD Anderson. And that's when I called MD Anderson. And so I have this long 22 plus years of experience at MD Anderson. And fortunately, I've had the same doctor for 22 years.
Wow. Thank you, Dr. Pitre, for sharing. Again, when you listen to Dr. Pitre's reflection on his breast cancer journey, it is a true reflection of, number one, self-awareness, right? Imagine he did not identify that a lump on his chest was abnormal, right? If he had waited longer, things would definitely not have panned out the way it has. Obviously, breast cancer diagnosis or cancer diagnosis in general is not anything that anyone wants to hear, but that self-awareness to say, hey, this is not normal, let me go check it out. So
Okay,
thank you,
well,
Dr. Pitre, for sharing
well,
that with us.
in 2015, I was going to do annual exams, and every year came back says I was okay. And this time, when I went to do the exam, I was thinking about buying this new car and stuff, and going to play golf. And when I went in to do my exam, the doctor said, I told her she was never going to be a good poker player because she didn't have this face. And I said,
Mm.
what's wrong? And so she says, I need you to go do another couple of tests. And when I did the test, it came back that I was stage 4. And then we know that normally you live, what, 5 years, and it's been since 2015. So
And years.
so you're not speaking to a dead man. I'm supposed to
Oh,
be
yeah.
dead. I'm supposed to be dead by now, but uh, you know, if it's okay with you, I'd just like to share with you uh, what I think saved me because I have a process I follow. One is prayer. I mean, I believe in the power of prayer. It's just greater than me and all of the other things I do. But then the next level would be the doctor. Uh, and as I said, when I first diagnosed with breast cancer, I was assigned this doctor, and the nurse practitioner came in. She says, "Who are you assigned to?" And she says, "No, there's a lady over here that works with men, and I'm gonna change your doctor." And that happened
Mm.
to be the doctor. That's my doctor now, who in fact, throughout these years, I've watched her grow because she's now over the breast cancer center at MD Anderson, Dr. Geraldana. And so then the next thing after the doctor says, well, okay, if the doctor tell you you need to do all of these things, then why would you have a diet that violates basically everything that the doctor tells you? So what I did on my own was to research and create a diet that would be compatible to managing my estrogen, which is because my cancer was estrogen positive. And then the next thing was exercise. I have
Mm.
lost over 100 pounds from the time I was first diagnosed with breast cancer to now. And
Wow.
I've been hospitalized a couple of times, but it has always been because of the medication. I have had no serious pain in the 22 plus years of the breast cancer. And so as Dr. Hunter explained earlier, that excess alcohol and tobacco have negative effects on your survival rate. And I fortunately didn't know at that time, but in um, when my daughter finished high school, uh, I stopped drinking, and I haven't had a drink since December 18, 1997, 2 o'clock p.m. was my my last my
Wow.
last drink of alcohol. And so, and I never did smoke. So, but that's basically a short form of my story.
Thank you, Dr. Pitre. I mean, again, just sitting here listening to how you had that initial diagnosis right over 22 years ago, and now a reoccurrence in 2015, which, like you said, stage 4 disease is technically considered terminal, but you're here 10 years later. And thank you for sharing the practical tips: diet, exercise, prayer. Definitely, that's a lifeline. I am a person of prayer too. And I know that God keeps us all safe and sound. And, smoking, alcohol cessation, all the things that Dr. Onta reflected on earlier. So thank you, Dr. Petre, for sharing this. You kind of highlighted a little bit into my next question about what hurdles did you face? Did you have any misconception? It seemed like you basically landed in the right hand, right, of your physicians, your medical team, were the right group of people, which is definitely very helpful. But through this journey, did you face any misconception, any delays, any insurance related issues, or any barriers in navigating the healthcare system as a male breast cancer survivor?
Well, I grew up on a farm, and I lived with my grandmother, so I developed a stubborn experience and attitude over life.
Mm.
So my attitude is that the doctor has a role and I have a role. And so I always have these conversations with my doctor and explain to them that I respect you as a doctor, but you need to respect me as in charge of my life because I'm the one that's in charge of my life. You're there to help me and assist me. And so the one of the reasons why I'm still with this doctor is because she and I has a magnificent relationship. I mean, she we we honestly explain or express to each other how we really feel about something. And I know I've been on several different medications, and one medication she was going to put me on, and I said, I'm not taking that. And she said,
Mm.
What? What did you say? I said, I'm not taking that. And she says, Why? I said, because it's not much different from what I was on before that didn't work. I said, the only basic difference is it's from a different pharmaceutical company. And she says, hadn't thought about that. Maybe we better look at it. As a result, I was on something else. But so I've changed medicine several times. But the key thing is that most of us um, oftentimes will not express how we really feel to the doctor. If the doctor say do this, we do. Well, the doctor might know what's wrong with you medically, but you know what's wrong with you in a total different perspective from which the doctor understands. You know, it's kind of like I've been associated with TSU for over 50 years now. I'm a professor of accounting, and I tell the students I teach an ethics class and I teach a financial accounting class, and I tell them that in the ethics class we all have opinions. In the financial accounting class, it's all me, you know. So we have to understand who's who and how this relationship works. And so it's just been, if I could never explain the beauty of the relationship between Dr. Donna and I. And so that's a major reason why I'm still here. And plus, I believe if you say you believe in God,
Yes.
then you should act like it.
Absolutely. Very well said, Dr. Pitre. I mean, thank you again for your insight on not just resilience, but making sure that as a patient, you still maintain your seat in the driver's seat. You are the pilot, right? You never want to exchange that pilot seat for someone else, but having that really collaborative conversation with your healthcare providers, knowing that your perspective matters. So thank you for reflecting on that in this conversation. Dr. Onta, I have a question for you. You did share about some of the treatment options broadly, for breast cancer treatment in general. But I'm sure my audience is curious, just the same way I am, to say, are there any differences in how a male patient will be treated compared to females when it comes to breast cancer?
I could answer.
Go. Yeah, I was about to
That.
say. I think you. We got somebody that got some of it in real
Yeah,
life, but I'll let Dr. Petrie start, and I can maybe
you can
finish this
close
off.
it
And I
out.
think there's something in the chat also, and I'll answer that question after Dr. Petrie finishes.
Well,
Awesome.
one is that, for me, the type of breast cancer I have is hormone sensitive. And so men and women have hormones. Men have, what's the prostate thing? Hormone, and
Testosterone.
testosterone, and then the women have estrogen, but they have a common relationship, and that is basically men and women get treated with the same medication, with the exception of the matter of fact, I just had the shot yesterday. What is that injection?
Are you on Lupron or Zoladex?
Lupron.
Mhm.
So that's the difference, basic difference. But otherwise, the other medication I'm on is the same as women, and that's one of the problems is there's been a limited amount of research exclusively designed for
For
men.
males.
And that's because there are not as many, let's be honest, we follow the dollar. There's not a lot of dollars in men because there's not a lot of us with what? Breast cancer. So there's not, so that's one of the negative in the system. And it's because we are in a minority in terms of those who get breast cancer.
Thank you for that insight. Dr. Onta, please take it on.
Yes, and that is completely correct. What Dr. Petrie is referring to is the fact that regardless of Dr. Petrie's age, if he was diagnosed when he was 56, which is the youngest patient I've ever seen, male patient I've ever seen with breast cancer, versus being diagnosed at 76, he's gonna get that injection that shuts down the production of estrogen and testosterone. He's getting an injection called Lupron. There's another one called Zoladex. Both of them are effective at shutting down that process within your body from your brain, telling your body to make more testosterone or make more estrogen. If your body makes more estrogen, of course, it feeds the breast cancer because the breast cancer thrives on the estrogen that's flowing through your body. But with men, we always give that shot. So it doesn't matter your age. With women, we only give women that shot that Dr. Petrie is on when they're younger and they're pre or perimenopausal. So menopause makes it to where a woman would not need that shot versus a male. If I'm 56 when I get diagnosed or I'm 86, I still had to get that shot. So that's like one of the major differences is actually focused on the hormones while the chemotherapies and targeted therapies and radiation, all of those things are consistent with men and women.
Thank you
One
so
one
much for
other
that
comment,
insight. Yes,
one other
please.
comment I'd like to would be with the diet. One of the things I did, if you take your hand, and you look at the five fingers, well, my thumb used to be my vegetable, and the four fingers used to be my meat. Well, now
Mm,
it's the opposite. Matter of fact, I don't really care that much about meat anymore. But it's been 10 years since I've had any smoked meat or any processed meat or any red meat. So I drastically changed my diet, and that was one of the reasons how I lost over 100 pounds.
yes, you lost the pounds, but hey, you are still here with us, right?
Well,
10 years
I'm happy
after,
I lost the pound. To be honest
but
with
you
you,
are here with us.
the whole breast cancer process for me has not, the breast cancer itself hasn't been bad. The worst part of my life has been the fact that COVID came and I had to stop playing golf because of the association with people on the golf course. But so, you know, it's you live with what you have to live with, and if you say like I said earlier, if you say you believe, then believe.
Very well said, Dr. Pitre. That honestly takes me to my next question for you again, Dr. Pitre. How has your treatment, all the endocrine, surgery, chemo, how has it affected your day-to-day life? Any impact on your body image? You've shared with us that you lost some weight, you were not able to go back to golf, has it impacted your sense of masculinity? I know that is a touchy, sensitive topic, but please, whatever you're
Well,
comfortable sharing with us, please go
it's
ahead
just a
and double check.
reality sympathy. It has a dramatic impact on your social life. If you want to be just kind of soft about it,
Yes,
you can take that to the further. It does have a a problem. It creates a problem because when you're on the Lupron, um, it eliminates your abilities to do things.
right. Yeah. And that definitely, leads to some social support and the social needs. And thank you for, staying through, with the coping mechanisms and, having that support system beside
Well,
you to
I've
ensure
been
that you continue to try, this
I've
job.
been married for 46 years.
Hey, I think I need to do another panel discussion with yourself and your wife. If you
Well,
will
I
let
don't
me
know
know.
about all of that. Now I said I've been married for 46 years. She probably would not agree with most of what I say, but no, it's been a wonderful life, and she's been a tremendous support in this process because what in terms of the diet, she in effect ended up changing her diet to the extent to which it uh, accommodates mine. But I also have enough sense to know that we can sometimes have different plates, so
Right.
it hadn't totally eliminated the things that she used to do because she still eat pork ribs.
Right, right. Kudos to all the support systems out there. We love them and we always cheer them on. That is amazing. Dr. Anta, I know you mentioned there were a couple of questions in the chat. Maybe this might be a good place. I'm looking at our time. We have only 10 minutes left. It's been a really great conversation, but I want to make sure we also make time to answer some of our audience-based questions. Dr. Anta, please.
Sure, sure. So I had answered the initial one that I got, which was about the age, and like I said, 56 is the lowest age I've ever seen of a male patient diagnosed with breast cancer. And then there was another statement about a male who had found a lump, and they did a mammogram, and they decided the lump was not cancerous, and should it still have surveillance, and they have family history of breast cancer, and I would have a strong yes for continue to monitor. Outside of a biopsy, that's the confirmatory space to make sure something is not invasive, and if it is an abnormal lump, monitoring the size, making sure that everyone is aware of it. That's a key thing because things can get missed and do get missed more often than you might think, especially in male patients with breast cancer. So that would be something that I would monitor personally, and I would have it monitored from an imaging perspective if I was that patient or that man.
Thank you. Thank you for answering those questions. And I think I have one or two more questions for you, Dr. Hunter. You kind of segue into follow-up and survivorship, right? Because once the disease is diagnosed, and regardless of the stage, what type of survivorship should a male patient be conscious about? Dr. Petrie has openly shared his own playbook, right? He has told us about diet, exercise, alcohol, cessation, smoking avoidance and things like that. But on a more, broader scale, what will a follow-up and survivorship care look like for male patients with breast cancer?
Yeah, absolutely. So, I guess to take you through the scenario start to finish when a patient will get, let's say you get diagnosed, because Dr. Petrie is actually in a unique situation where he was diagnosed at stage 4. So I'm sure that they're still following him closely, even as of today. And that's why he maybe has such an intimate relationship with his oncologist. Historically, if you do diagnose a patient early enough to where you do get a point where they are off of treatment for long periods of time, you typically are going to follow that patient after you finish all your treatments. That means your radiation, your chemotherapy, your hormonal therapy, which that in itself is going to take 5+ years to get done. That's the best case scenario. So we have some patients that stay on for as much as 10 years, but you at minimum are going to be on all of those treatments, and all of this is going to go on for 5+ years. After that, we start to monitor patients like every 3 months, usually for 1 to 2 years, and that would then increase to every 4 months for another year, and then we go out to every 6 months for a year. And by the time we monitor them for about 5 years with that more frequent monitoring, we then will do annually for the rest of their lives, actually. And this involves imaging, this involves labs, this involves mammograms. All of these things are being done throughout all of that time when they're in survivorship, where they have received their treatment, but we're still watching and making sure that cancer doesn't show its head again. And if it does, we can react very quickly.
Awesome. Thank you for sharing that with us, Dr. Hunter. My next question is for Dr. Petrie. Dr. Petrie, just listening to the survivorship and follow-up plan, right, that Dr. Hunter laid out, it's a lot. It takes a lot to keep up with all this schedule. And I'm very grateful that you've also highlighted on the support system, that you've received from your wife and maybe also from your church, because, you've shared that you are a person of faith. But are there any other support resources that you found, available out there, maybe online, maybe in-person counseling, peer support resources that is available specifically for male breast cancer that you will be able to share with our community today?
Well, I probably got good reviews up to this point, but when it comes to the people side of it, I look at the completely different. From most people expect too much from people, and people say, so and so is my friend. Well, when the last time you heard from him? Or it's been about 3 years. Well, what kind of friend is that? And so I I have this relationship with me with God, and so so I think between me and God we can solve anything. Now, I've never met God. I've never had him talk to me like I'm talking to you, but I believe. So he sends people to your life. But what happens with us is we want to tell him how to perform. He'll send somebody to your life, but that's not who you want to come to your life. So you ignore that person. And so that's how we miss out on a lot of things that's beneficial to us in the process. So uh, we like I used to play golf with some guys, and we played golf every Friday. So on Thursday they call me and say we're gonna play Friday at such and such a time. We meet, And so then I don't hear from them again until next Thursday and see them that Friday. And so on and on. Well, then when I got cancer, I stopped hearing from them.
Mm.
Well, the normal thing for an individual is to get upset. Well, we weren't really friends. We were golf partners. And so we weren't playing golf anymore. So there wasn't any reason for them to contact me. So
Wow.
once I understood that, then it was easy for me to deal with why they stopped communicating with me. Then we never communicated beyond golf to start with. So a lot of
Right.
times we our expectations are too high for people, and stuff. So like I said, so for me, my the thing that's carried me through is like I said, my faith in God, uh, my wife, my doctor, my daughter, and we don't really, for me, and as I told you, I'm not a good person to answer that question. 'Cause for me, I don't believe that I need all these people around me. You know, I,
Right. Hey, your,
I,
your your perspective is very, very valuable, and it brings to the point that the expectation when you don't have that high expectation, it reduces your chances of getting disappointed, and you're able to, just live and keep up with the resilience and the coping skills that you've generated over time. Thank you so much. This has been an incredible conversation. I'm keeping an eye on the time. Dr. Onta, do you have one last statement, maybe 10, 15 seconds, real quickly, to share with our audience? And then one last statement from Dr. Petrie after you, Dr. Onta. Please
Yeah,
go
most
ahead.
definitely. Yeah, most definitely. I think that I would just, kind of close with just echoing the sentiment of like health and how healthy you are as a man, and that being one of the top things that can help you with this particular type of cancer. Those hormones are circulating, and you don't think about hormones when you think about being overweight, but it directly is related to the amount of hormones you have circulating if you have more fat tissue. So that's something to really think about if you take anything away from today when you think about decreasing your risk of breast cancer as a male.
Thank you, Dr. Onta. Dr. Petrie, any last comments?
yes, I would just like to say that I echo the weight and the diet thing. Because the most amazing thing that fascinates me most is, like I say, I'm I spent 8 years as uh, what are those helpers at the hospital? Uh, a
A
volunteer.
volunteer.
I volunteered, and I learned a lot about human relationships. There was a doctor there with cancer, and he was a cancer doctor. His wife was an eye doctor, and when I was volunteering, I'd speak to people like just listen to them. And she was crying on my shoulder, and I'm saying to her, "But you're the doctor, and your husband's the doctor.
Mm.
I'm just a patient." But so you'd be surprised the relationships that you can develop when you're going through a process like that. And so I speak to people about what I'm going through, not because I'm seeking any support or any cancer, but I think that that's part of what God would want me to do to share with people on how they can go through this process. And one of, as Dr. Hunter said, for me, the number one process is people are just, oh, there's a lot of people that's overweight. And you just go to the hospital and you see all these people that working at the hospital that need to lose weight. And if you look at most of what happens in our health issues in life has to do with our weight. And I mean, it's just uh I have this picture in my phone that shows this shirt that I used to fit me when I was in 201. And after I got cancer and lost all that weight, it looked like a nightgown.
Mm.
It's,
Wow. Wow,
but
wow, wow.
I would just say that I think we need to have more of these kinds of discussions because men are just stubborn and we don't want to go and see the doctor because we know everything, you know. Nobody can tell us anything. And so
Yeah.
I've tried to develop this relationship with a doctor. Every time I see a new doctor, I said, this visit is, we need to get to know each other. And I've had some experiences with some wonderful doctors in my 79 years of living. So I'm speaking to you from heaven.
Yes, and yes, very well said, very well received. Thank you so much, Dr. Pitre, Dr. Onta, for sharing from the depth of your heart, and Dr. Pitre for sharing sincerely from your wealth of experience, your resilience, and everything you shared today. Will definitely go a long way to help us have a healthier and a better community. Because of the time, I'm going to be closing out with just a couple of announcements.
Can I say one thing? That I'm available for if you ever want somebody to speak about male breast cancer, you can always call me.
Absolutely, Dr. Pitre. Today's session definitely tells us we need to have more of this type of conversations. And I truly appreciate you. Thank you so much. And to all our audience and attendees, thank you again for joining us. For everyone who is a community worker that would like to receive credits, please go ahead and scan the QR code or click on the link that we've been posting intermittently in the chat box so that you can receive your credits after this. A couple of other announcements. We do have some upcoming webinars. This same time tomorrow, we will be talking about respiratory health. You can scan the QR code and you will be able to register for that. In January, by God's grace, we would have another outreach focusing on maternal and child health. This is going to be in person as well as online. Details are currently on your screen. Feel free to scan the QR code and that will take you to the link for you to pre-register. In March, we will focus now on breast cancer again, where we will talk about, is screening mammogram a painful experience? This is something that we've seen an ad of. We did the same webinar last year and we had very great engagement, and we are doing part 2 of this same content where we will do our best to answer the question, is screening mammogram a painful experience? The registration is already available online. Go ahead and register for that. It's going to be a Zoom webinar as well, and CHW credits will be available for that session. Save the date, Wednesday, March 4th, 2026, from 12 to 1 p.m. by God's grace. Dr. Pitre mentioned, during his presentation about the inadequate resources and clinical research for male breast cancer. So here at Texas Southern University, we have the privilege to lead several events, one of which is on clinical research. So we would be having our clinical research and engagement conference in April 18th, 2026. Save the date. It's going to be both in person and online. Like we announced earlier, we already have our mobile unit. It's already here in Houston. If anyone is willing to support, partner with us, feel free to reach out to us, send us an email, give us a call, and we will be able to walk you through how we can, receive partnership, sponsorship, and all resources that we need to mobilize this mobile unit for its full operations. Not only do we just talk about clinical research participation, we have recently launched a clinical research registry that allows community members to participate in clinical research here at Texas Southern University. If you are interested in clinical research participation, then our clinical research registry is for you. Scan the QR code or click on the link in the chat box. That will take you to that place where you can complete the information. Or if you have questions, feel free to reach out to us and we will be happy to provide you with more information. Thank you again, everyone, to all our support staff members, Constellation X, Lauren, everyone on the call for supporting today's event. Again, reminding us that this is Texas Southern University Breast Cancer Screening and Prevention Center. We received funding from CPRIT. CPRIT is the Cancer Prevention Research Institute of Texas, where we provide navigation services, education, and no-cost mammogram. To request information or to partner with us, you can, call us, email us, or scan the QR code, and we will be able to reach back out to you. Dr. Petre, Dr. Anta, we are extremely grateful to you all for sharing your insight with us today, and wishing everyone a great rest of the day. Thank you, everyone, and have a wonderful rest of the afternoon. Hello again. My name is Veronica Ajewale. I want to say a big thank you to each and every one of you for joining us for today's program. I am very certain that you have received a lot of great information that you will put to practice as we all grow together to become a healthier community. Thank you to our speaker and our panelists. Thank you for sharing today's content with us. Thank you to our locations. Thank you to our interns, our volunteers, to our sponsors and our funders. Thank you also to the staff of our program, the faculty, and the leadership of Texas Southern University for supporting us in making today's program a success. Most importantly, I want to say thank you to each and every of you, the community members. We appreciate your support. We do not want today's program to end just with today's event. We want you to continue to collaborate with us and engage with us. Our social media platforms are located at CECTX Southern U. On those platforms, you will find engaging information from today's program and all the other programs that we have going on in the Community Engagement Corps. So we implore you to continue to stay connected with us, engage with us as we move forward together in building a healthy and a wealthy community. Thank you for joining us, and we look forward to connecting soon. Bye.